My name is Subin Valayil. I am a PA within our general thoracic surgery division at Baylor Medicine. I function primarily in the outpatient clinic, so I'm not in the OR. I see patients primarily pre-op, post-op, and for follow-up for questions and concerns in between. Primarily, the things that we see are basically benign malignant disorders of the chest cavity, so lung cancers, lung nodules, lymphomas, mesothelioma, disorders of the diaphragm, and such. Hoping to provide you with information today on something that we see very often in the way of gastroesophageal reflux disease, brief and general guide on how we treat and surgically manage these patients. I think I'm the last person that's standing in the way of lunch, so I should be brief and quick, but we'll get through this together. Before we get into it, just wanted to highlight to everybody that I work with back at home. Up top, we've got our surgeons. I support 4 surgeons. My outpatient counterparts are listed below them, as well as my inpatient counterparts. Not pictured here are the ancillary staff as well that I work with, nurses, the call center team, schedulers, medical assistants, coordinators, our lead APP, Holly, as well within our Department of Surgery. Pride ourselves on the clarity of purpose and the focused attention that we're able to provide to our patients, and just thankful that I get to work with these people every day. These are our learning objectives for today. Hopefully by the end of this presentation, we'll have gone through each one of these, but identifying the clinical indicators and diagnostic findings for referral for surgical eval in patients with GERD. Understanding the principles and procedural steps of common thoracic surgical interventions for reflux, including laparoscopic/robot-assisted fundoplications, as well as the emerging alternatives. Recognizing post-operative care needs, complications, and expected outcomes to support patient education. All right, so getting into it, epidemiology. Reflux, as many of you guys know, is pretty common and one of the most common disorders seen in the general population. The exact worldwide prevalence otherwise remains uncertain despite its recognition as being common. The ACG defines GERD as being chronic symptoms or mucosal damage as a result of abnormal reflux of gastric contents into the esophagus. That definition was later expanded to include primarily that reflux resulting in symptoms and/or complications. GERD is pretty common, and as we know here in North America as well as Europe, with the prevalence of younger patients having GERD and that number increasing. I highlight the number here, 20%, because according to the National Institute of Diabetes and Digestive Kidney Diseases, approximately 20% of adults in the U.S. experience GERD symptoms at least once a week. I think that number, though, is somewhat shortchanged. If we're going to take a poll in this room, how many of us here have experienced GERD over the last week? I was hoping it'd be more than 20, I think it is. But primarily, the way that they attested to this number was through symptom-based screening tools. And GERD symptoms can range in regards to how they present, both esophageal as well as extraesophageal symptoms. So now getting into anatomy, just want to highlight here a few things. I don't know if the point of working, but the esophagus, lower esophageal sphincter, as well as the stomach picture there. Want to take note of the LES for the lower esophageal sphincter here, as well as the few more points on the next slide. But the LES is a zone of high pressure. It's located within the GE junction and primarily below the diaphragm. It's ringed circular muscle that's present there and in a state of chronic contraction. Usually what happens is that that contraction is basically the hallmark of the LES, and relaxation happens about 2 seconds after we initiate a swallow. It distinguishes it from the rest of the esophageal body that's otherwise pushing food down into our stomach. Primarily would state that the LES is probably the most important component of our anti-reflux apparatus. Competency of this LES, though, is determined by 3 main measurements: the overall pressure of the LES, the overall length, and the intra-abdominal LES length as well. Normal pressure ranges from about 10 to 30 milligrams of mercury. The overall length is about 2.6 to 5.4 centimeters. we were to visualize that measurement, it's about the height of a credit card. A credit card measures about 5 centimeters in height. And then normal intra-abdominal LES can range from 1 to 4 centimeters in size. So now again, further into anatomy, we've got the positioning of the esophagus in relation to the stomach. Here we can see the fundus, or the top portion of the stomach, as well as where the esophagus sits, which is not necessarily on top of, but at an angle. And that angle attachment refers to the angle of His. And that's important when we talk about counteracting the tendency to get reflux. I bring this up because in February of 2022, the American Journal of Gastroenterology conducted a study of about 57 people with chronic heartburn symptoms. Those 57 people with chronic heartburn were basically monitored during their sleep. They had them laying on their left side, their right side, or on their back. When you look at this picture, and what they found was that acid cleared much faster when patients were lying on their left side as opposed to their right or back side. Sleeping on your left side, what that does is the stomach is positioned below the esophagus, and if that LES isn't working as it should, gravity can keep the acid in the stomach and prevent it from rising up into the esophagus. Versus when you sleep on your right, you've got the stomach above the esophagus, and in turn increasing the likelihood of acid exposure. So getting into the pathophysiology of GERD, as mentioned, the LES is a very important part of our acid reflux barrier, but intermittent reflux can be considered normal. And there's several factors that can influence how bad the reflux can become. Part of that is how well the esophagus pumps, the strength of the LES, as mentioned, pressure differences between the chest and the abdomen, support from the surrounding crural muscles for the extrinsic LES, integrity of the angle of His, and how quickly we empty things out of our stomach. Now we get into more of our surgical landmarks and things that we take note of when we proceed with surgical intervention. I want to highlight here the esophageal hiatus that's pictured, the left vagus and right vagus nerve as well, as they control the release of digestive enzymes, the gastric acid and bile that manage the contractions of the stomach. We see the right crus and the left crus of the diaphragm as well. So a big word, or words that are associated with reflux, are a hiatal hernia. What that basically attests to is a displacement of that LES at the GE junction from the esophageal hiatus. How this kind of develops is somewhat still unknown, but it's likely due to the weakness of supporting tissue around that area. Several factors can cause a hiatal hernia to develop, including obesity and increased abdominal pressure. I want to take a pause there at that point too, to kind of have us go through a little breathing exercise. So I want to have everybody just take a deep breath in and out. All right, so as you breathe in and out, the pressure within the thorax changes. It's largely negative, and that's what draws the air in, and air equalizes with the pressure from the outside. Now, as you push air out or take a deep breath out, what you're doing is increasing that pressure in the abdomen, while the thorax pressure is more so low. So coughing, lifting, straining during bowel movements can kind of increase the pressure within the abdomen to a low pressure system in the thorax, and in turn may attest to sometimes those abdominal contents going to the chest. Pictured here, we've got a depiction of the displaced LES, as well as a large gastric hiatal hernia. So traditionally, hiatal hernias are categorized into two subcategories. There's 4 subtypes here, but there's sliding types as well as paraesophageal types. Type 1 is considered a sliding type versus type 2 through 4 being paraesophageal hernias. In type 1, what you see is a displacement of the LES. Primarily up there, you can see just the LES is up, and what happens is that it'll go up and down. In type 2, you've got displacement of the fundus. The LES is still somewhat below the level of the diaphragm, as you can see there, but the top part of the stomach is above the diaphragm. In type 3, you've got the LES above the diaphragm as well as the fundus of the stomach. And then in type 4, LES is up there, the stomach is up there, as well as an additional organ is usually included with the stomach there as well. At the point where we get to a type 4, stomach herniates, and there's potentially concern for emergent intervention in the way of potential to turn into a gastric volvulus if the stomach may twist, kink, or lose blood supply. So symptoms of GERD. Typically what patients experience when they attest to symptoms of GERD, they say that they have heartburn, they've got acidic taste of regurgitation. And then we have patients that present with atypical symptoms that can kind of range in the way of cough. You wake up with a hoarse voice or changes to your voice. You got tightness in your chest, atypical chest pain. A lot of patients that we see as well will present to the ER in the sense of thinking that they have cardiac etiology, will get worked up on that end and then end up finding out they have reflux. Then as well, you can get pneumonias in the way of aspiration from the acidic contents coming back up into the airway, and then complex symptoms including dysphagia, odynophagia, as well as hematemesis. So if GERD remains unchecked, things can kind of develop down the line in the way of peptic strictures. And as that name implies, it's basically a stricture of the esophagus, usually the distal esophagus, in the sense of the peptic contents of the stomach, causing the esophageal narrowing. A stricture is usually defined as something in which the esophagus is about 13 millimeters or less in size. The normal esophagus has a diameter of about 30 millimeters in reference to that. You can also develop Schatzki's rings or short web-like stenoses associated with GERD. Really what that is when you think of a plumbing or a kind of tube fitting, you think of a ring and maybe a washer setting. So you have a washer and then a smaller ring inside that washer, and that smaller ring is what we refer to as that Schatzki's ring. And then after that, if GERD still remains unchecked, you can develop Barrett's esophagus. I have pictures of this to follow, but usually our pale pink stratified squamous epithelium of the distal esophagus is then replaced by this beefy red, scary looking columnar and intestinal mucosa. There's staging to this as well in the way of what's considered short segment and long segment. Usually when it's less than 3 centimeters, it's considered short, and long segment is considered greater than that. Progression can then result in the way of dysplasia when you have these changes of the esophagus, from metaplasia, which is basically an abnormal cell growth, but more so a benign change. But you get dysplasia, which is characterized by the change into, which can occur into adenocarcinoma. And that change happens in about 14 months. So pictured here, we've got normal anatomy, and then next to it, 2 instances of Barrett's esophagus. The pink is what we characterize as normal tissue versus the red, which would be the Barrett's. Primarily, I show these pictures too because surveillance is very important when it comes to Barrett's diagnosis. Every 3 to 5 years, if there's no dysplasia noted, usually is the time frame and length in regards to surveillance, but the interval can change depending on the degree of dysplasia versus metaplasia and what things look like on pathology. This was a pants pearl and something that I had to know for, I think when I initially took it, I remember a question regarding this, but Barrett's esophagus is the only known precursor to esophageal adenocarcinoma. We preface this to our patients too when they come in with a diagnosis of Barrett's that anti-reflux surgery is not considered a cancer prevention surgery, primarily there for symptom control and quality of life in that sense. But once, and that's why we go back into the surveillance of Barrett's being very important. There's no unequivocal data to support that anti-reflux surgery is, in the sense of prevention of Barrett's, available. So once Barrett's diagnosis is made, surveillance remains a viable thing that we need to follow up on in patients. So management of reflux. Primarily when patients have reflux, they usually start with lifestyle modifications, avoiding tobacco, caffeine, things that may trigger the reflux symptoms, as well as weight loss and avoiding 3 hours before bed. We talked about positioning as well, elevating the head of the bed too. Once that may not work, then they turn to antacid therapies that you can get over the counter, as well as prescription options. You've got H2 receptor antagonists such as famotidine, and then PPIs, omeprazole, Nexium, some of the other ones. utilized in the sense of healing esophagitis. The patients will usually have those PPIs on board for about 8 weeks in time to help heal that inflammation that they have there. Now, more recently, we're getting into PCABs, which work on the same channel as PPIs, or at least they're potassium competitive acid blockers. They work a little bit better than the PPIs, more so in the sense of they're longer acting, they don't need enteric coating, they don't need necessarily dose administration too before meals. As they've come out, though, they're a little bit more so expensive, but patients do favor that if it is an option for them. Once all this has kind of been exhausted, we'll get referrals from the GI physicians, we'll get referrals from the family medicine physicians in regards to surgical management. So the indications for our patients that we see for surgery are those that don't respond to high-dose PPI therapy, those that don't tolerate PPIs, or those that don't wish to be on medications long-term. Usually when we have a type 1 hernia or somebody that's undergoing elective repair, we order a slew of studies to help diagnose and help manage and tailor their intervention for them. Part of that evaluation consists of an esophagram, pH probe analysis, esophageal manometry, an upper endoscopy, and sometimes a gastric emptying study. We'll get into all these studies and what they are and how they go about getting the studies here as well. Sometimes, though, asymptomatic paraesophageal hernias may progress to larger symptomatic hernias and lead to emergency presentations. As we previously saw, those type 4 hiatal hernias may then lead to emergency presentations. Before our elective surgical interventions, usually these 3 things are quantified in the sense of objectified evidence of abnormal reflux exposure, endoscopic esophagitis, symptoms of reflux, as well as, more importantly, a BMI less than or equal to 35. That last part we try and stress in our patients when they come and see us for elective repair. Patients that will have a BMI greater than 35 usually will have some form of recurrence post-operatively early on in regards to surgical intervention. So we try and stay away from seeing these patients, or at least offering the intervention if their BMI is greater than 35. If they come to us and their BMI is more than 35, then we'll offer them the option as in regards to medical weight loss or even a referral to bariatric surgery to consider reflux intervention. So going through the studies that we order, first, as mentioned, objectifying or quantifying their reflux by a pH evaluation. I'll show pictures of this here later, but there's options to do that in the way of a wireless pH probe and impedance pH catheter, which basically will attest to how much reflux is coming up into their distal esophagus. Additionally, we'll get a motility evaluation, making sure that there's no underlying motility disorder or anything that may be impeding how things are moving through the esophagus, and we'll do that through esophageal manometry. And then as well, we'll assess the mucosal effects of the reflux that they're experiencing via EGD or a baseline contrast study in the way of a barium swallow. So pictured here, we've got the pH evaluation. Primarily what's utilized most is this wireless pH capsule pictured on your right side there, but it's endoscopically placed by a GI physician. The patient will be off their PPI medication for about 7 days. GI physician will have the patient asleep, do an endoscopy, place this capsule down there. Patient will be sent home with this little receiver pack that over the course of 48 hours, they'll attest to symptoms, go about their normal day, press the button when they notice that they have heartburn, reflux, regurgitation. When they do that, the catheter, or at least, the monitor itself will then coordinate with the patient's symptoms, as well as if reflux episodes are happening, and generate a report for us that's available about 2 weeks after the study is completed. The capsule itself sloughs off on its own. You don't have to necessarily worry about collecting it or grabbing it after the study is completed, but we do need that receiver pack back. Alternatively, you have the impedance pH study, which is a little bit more so uncomfortable. The patient has this catheter that stays in the distal esophagus for about 24 hours, sent home with this battery pack as well. That's recording the pH in the esophagus during the time of their study. This is primarily used too in the way of identifying non-acid reflux episodes as well. When I reference that, acid reflux episodes are primarily defined as a pH less than 4. We have come up, or at least Dr. Demeester has come up with a score in regards to using a special formula to help assist in objectifying these symptoms for patients. When we generate a report, we'll get this Demeester score from our patients, and a score greater than 14.7 is considered abnormal or notable to state that, hey, this patient has reflux, maybe we should do something about it. There's different parameters that are utilized to help calculate the score, including the total number of reflux episodes, the duration of the longest reflux episode, and reflux episodes lasting longer than 5 minutes. Another study that we utilize, as mentioned, is to make sure that the esophagus is pumping as it should, and measuring the pressures within the LES as well as the upper esophageal sphincter as well. This can be somewhat uncomfortable for the patient, but gives us good information. They're not necessarily asleep, even though this guy's eyes are closed. It's done while the patient is awake, and the nurse will administer a local anesthetic to guide the catheter through the nose. The patient will then take a few sips of water, and as these sips of water are taken, the tubing is giving us sensor readings of how well the esophagus is propulsing that food down, and will give us a reading as well, LES. Pictured here, we've got another study that we usually order as a baseline for our patients that come in to see us. This is an esophagram, contrast going down into the esophagus and stomach there. Pictured here, we've probably got a type 3 hernia and displacement of the LES as well as the fundus above the diaphragm. As you can see, both the right and left diaphragm sitting there as well as the stomach sitting above it. So going back to our operative candidates, primarily what we do before we offer an elective surgery for our patients is have objective evidence of abnormal acid exposure, or ensure that there is endoscopic esophagitis, correlate with their symptoms as well, and then ensure again that their BMI is less than 35. So now getting into the actual surgery part of things and the history of all this. Prior to the 1950s, what was done was anatomically just put everything back to where it was. Long-term outcomes and research on that found that that was not very successful. So in the 1950s, somebody named Dr. Rudolf Nissen came about, and he was confronted with a patient that was about 49 years old, had chronic symptoms. And what he did was a transabdominal approach in mobilizing the distal esophagus and then wrapping the distal 6 centimeters of the esophagus with the gastric fundus in an effort to correct the GERD that she was experiencing. That laid the foundation for future advancements, and then progressively we got into laparoscopic techniques in the 1990s. 2000s, you then have the robotic approaches, and then 2010 kind of got into more of tailoring these approaches with the previous mentioned studies that we have now. So what does surgery involve? Primarily, surgery involves repairing that hiatal opening, as well as reinforcing the LES at which we've got our problem. So usually that happens with a fundoplication of some sort, or at least reinforcement, and we can talk about what's coming in regards to how we proceed with that fundoplication. So pictured here, we've got our hiatal opening now closed there behind the wrap. You can see the stitches that sit at the hiatal opening there. You can't necessarily close that opening all the way, right? You gotta get the food down into your stomach somehow. So the stitches are placed there, as well as allowing for the esophagus to sit with an intra-abdominal length of about 3 centimeters at length. Usually what happens for creation of this wrap is a bougie is placed down and the stomach is wrapped at the distal esophagus. The procedure itself takes about 2 to 3 hours to complete. Listed there, I've got kind of the procedural steps that we outlined as far as what's done to do that. These are now variations of the wrap that you can create. When we get our esophageal motility back, these are things that we would consider as far as how tight or how loose we want to make this wrap for our patients. On one side, you've got a 270-degree wrap. I'm going to go back to this slide. As with a 360-degree wrap, sometimes what you can see is propensity for patients to develop bloating or excessive gas post-op. As you can see, the wrap itself wraps all the way around the esophagus. So We all swallow air, and through the course of time may have, or these patients that are predisposed to bloating pre-op, we advise that we may kind of benefit from an intervention that would be a little less tight or at least loose in the way of toupee fundoplication, or what's pictured here, the 270-degree wrap. Then we get patients that ask, is one more beneficial than the other? In turn, no, and data to support both being effective options have proven to be true. Alternatively, you have the door fundoplication, which is a wrap that you kind of put over the esophagus, and is primarily reserved for patients that have achalasia, and usually is associated with a Heller myotomy, in which you cut into the lower portion of the esophagus there as well. So again, going back to how much intra-abdominal length that we need to proceed with a fundoplication, we have to have usually at least about 3 centimeters below the, or at least intra-abdominally. And if we don't have that, what's done is something called a paulus lengthening procedure. Take a wedge of the stomach out, and you're able to get more of the stomach there utilized as a new esophagus there, and wrapping the fundus in place of what we've got previously mentioned. Then what's come out in March of 2012 is this magnetic sphincter augmentation. What this is primarily a flexible magnetic ring of titanium beads that you place around the LES. A larger hernia that's over 2 centimeters, severe difficulty swallowing pre-op, and things that may require evaluation in the way of MRIs kind of preclude a patient from getting this placement done. But most of this is beneficial and a new innovation in the sense of it's more physiologic. It'll open and close as a patient swallows, and something that patients have found beneficial in place of an actual fundoplication. So going back to kind of the benefits and drawbacks of this device is the preserved ability to belch and vomit if needed. Not as long as a post-op stay as the fundoplication, where you're discharged home the same day with this device. And there's no dietary restrictions. We'll get into this as well here shortly, but with a LINX device in place, we advise that the patient snack every 1 to 2 hours once they get home to kind of help the scarring and the tissue that ends up growing around it, to allow for that to be a little bit more so flexible post-operatively. Early on, they may have some sensations of dysphagia. It is a foreign body in the body, and as well, going back to the MRI initiative of not having a patient that will have consistent MRIs in the future. It technically doesn't have the device, or at least when a patient gets an MRI, it wouldn't necessarily fly out of their body or anything, but it does technically demagnetize the device if the patient undergoes an MRI more powerful than a 1.5 Tesla, and then eventually they'd have to take it out. So post-operative management for our patients, usually what we have them do is we'll have them NPO the day after with an NG tube in place. Tube is removed after the morning of to prevent any post-op emesis and a fresh repair. We'll get another esophagram at some point, often 1 to 2 days after the surgery. This depends on the surgeon. Some of our surgeons order this evaluation at their first post-op visit, which is about 2 weeks post-op. Have them up and moving on a clear liquid diet the morning after surgery, and staying on this whole liquid diet for up to 1 week, and then seen at the clinic 2 weeks post-op. We progress them through a diet progression for about 2 weeks after that on soft solids or anything that you can cut through with a fork, and then eventually back to regular foods. We maximize our healing potential at about the 6-week post-op mark. So we had advised them no heavy lifting for about no heavy lifting of 10 to 15 pounds during that 6-week interval. Now getting into when a patient has previous abdominal surgeries in the way of multiple repairs. I include this slide here because gastric emptying can become important, and going back to our surgical anatomy, the vagus nerves. Although likely multifactorial delayed gastric emptying is common following multiple revisions in that sense as a result of kind of the pulling on those vagal nerves and potentially injury to those nerves. We evaluate patients by getting a gastric emptying study, and that involves when patients end up doing this, or at least the consensus one that lasts over a course of 4 hours, they consume a meal that contains radioactive tracer dye that's trapped as it passes through the stomach. We all pass food at at an average normal rate, but in the sense that it's prolonged, we would be diagnosed with a diagnosis of gastroparesis. And to help assess with treatment of that, we would consider medications or something called a pyloric myotomy, in which we would cut the lower end of that pylorus there. And here are some of the things that we see in regards to a failed fundoplication or failed intervention. You've got a slipped wrap, a disrupted fundoplication in which one of the sutures come undone, a herniated fundoplication in which the wrap is now above the diaphragm, one that's too tight, one that's too long, one that kind of twists around the lower esophageal sphincter there, and then one that develops into two compartments. So etiology of failure often is associated with a timeline of when patients start to experience symptoms. Sometimes if you do have a wrap that's too tight, all it may require is just a simple dilation post-op. We usually kind of wait to assess and see if this is primarily just residual swelling from the intervention, give a timeline of about 4 to 6 weeks before that intervention takes place. Yeah, it requires a thorough history to delineate patient's current symptoms from what they experienced preoperatively to kind of guide that management. Additionally, if a patient comes to us and they've had previous interventions, it's always good to have their previous anti-reflux surgery notes to attest to what was done as well. Overall, just getting into recurrent or at least failed reflux interventions, every time a patient undergoes a reflux intervention after the first one, the percentage in regards to typical symptoms, or at least a success rate, decreases about 20%. So after the initial repair, if the patient presents with typical symptoms, the symptom quality in regards to improvement is about 90%. And the second time around would be 70, third time around 50, and of course going down that pathway. Redo repair primarily consists of taking down the initial repair completely and likely proceeding with a partial fundoplication. So as mentioned, when we have patients that have a BMI of greater than 35, or we think that they've undergone multiple repairs to the point where an anti-reflux surgery on our end isn't recommended, we talk to them about getting a referral over to bariatrics. Primarily what this is for consideration of a gastric bypass or at least a definitive anti-reflux intervention. You've got a smaller gastric pouch, primarily producing less stomach acid, helps in regards to weight loss, and as well as reduces the size of the stomach. So now just kind of summarizing what we've gone through in regards to our successful outcomes. Patient selection is very important. Providing the patient with appropriate evaluation in the way of the studies that we order, the surgical technique and which intervention that we take, as well as execution is important, as well as providing the patient with appropriate post-op education. It's actually the end of it, and these are our references here. Any questions? Yes.
How do you, after surgery, weaning people off their PPIs or taking them off completely, how do you typically do that? Do you go based on their symptoms or do you always take them off?
Yeah, so usually we end up taking them off of their PPIs. If there is a diagnosis of Barrett's, or at least preoperatively they have significant, usually with preoperatively if they have significant esophagitis, say so esophagitis is graded on a scale of A, B, C, or D, an LA grading scale that they utilize. If they have C or D, we primarily have them on a course of BID PPIs for about 8 weeks to assess for healing, and then a pre-op endoscopy is usually done before surgical intervention. If they come into us with Barrett's esophagus and they get their intervention done, then we usually send them back to their GI to kind of determine if the PPI is further needed, usually which it is. They'll be on a lower dose though, but usually they'll stay on that. But LA grade A or B esophagitis pre-op, no, we'll have them off. Yeah.
I actually have 3 questions. Sure. Sorry. One, what do you consider high dose PPI?
So for us, 40 milligrams BID. I know Dexcalent is one of those medications that can get up to 60. And so sometimes there'll be patients that say they have relief when they get up to 60 BID as well, but for us, it's 40 milligrams BID.
Okay, second question. If someone has like a Hill grade 4 flap, right, and they have a sliding hiatal hernia, how do you capture that? Like if it sometimes it gets stuck, sometimes it doesn't.
Yeah, so I guess going back, let's do it. So really part of the intervention involves kind of dissecting that area to bring everything back down to necessarily where it is here.
But before surgery,
Oh,
like
before
getting
surgery.
to that point, like how do you prove it's?
Yeah,
this
so
person
before
is
that-
Suffering with it.
Yeah, so before that, usually they'll come to us with, if not our clinic visit, we'll order a baseline esophagram, or at least, like you said too, if it's big enough, they'll probably have to present to the ER in some way, shape, or at least have an evaluation that elicits the, trying to get back to the esophagram here, but a CT scan too, in that sense as well, will depict that size of the hernia for us.
And then my third and last question, I know it's usually the obese, the older people, but I'm curious, are you seeing it in any younger athletes? I know someone who's a Division I athlete, heavy lifting in Division I sports, no other symptoms, non-smoker, healthy weight, and really struggling with this. So I'm just wondering if there's some changing of that.
For the most part, the majority of our patient population is somewhat middle-aged in that sense, and having had, or at least have had symptoms for quite some time. The younger population, not so much, in the sense of if they are younger, they're usually obese or have predisposing factors in the way of maybe a connectivity tissue disorder or something too, in which those muscles are a little weak. But yeah, increased abdominal pressure for sure can cause some of this stuff to result.
Thank you.
My question is about the post-op esophagram.
Yeah.
You say like most of the surgeons will order it 1 to 2 days after. Are there reasons why they like to order it? Because the surgeons I work with pretty much don't want to order it.
They don't want them after. Yeah, what's that?
Unless it's like some sort of symptom.
Yeah, I have one surgeon basically prefaces it that way as well. There's not really an indication in regards to the timeline of that. And really, it's just to make sure that before they proceed with sending them home, that everything looks okay. Because there may be a concern for esophageal leak that they don't know about. But kind of it goes back and forth in regards to symptomatology, or do you just get one just to make sure before you send them on their way? So yeah.
How long after gastric bypass can they have surgery?
How long after a gastric bypass?
Well, like, you go back to the gastric,
So with this, a lot of this, or at least the knowledge based on what I've got in regards to this is, we don't offer patients gastric bypass intervention. A lot of my intervention and what I do is diaphragm and above. So when it gets to the foregut and things, there'll be a referral in place. And primarily, again, the indication to get the patients over there is when their BMI is greater than 35, and they're more so obese in that sense. And if they've undergone multiple interventions where that tissue is fairly friable, we'd also say, hey, maybe it's worth considering this as an alternative to your multiple reflux interventions that you've had previously.